Look at us. All 4 billion of us, carrying the weight of the world. We create. We nurture. We balance everything. We spend so much time trying to keep up, struggling to fit in, and holding it down. It's not easy, but we have our good days. And then,
I would say the worst part of menopause is the unknown.
I want to know, am I normal?
I feel like the people at my age are trying to launch our children, take care of our parents, and then you put all that on top of your hormones raging. I just feel like it's a lot to handle for anybody. But yet, please do it and show up every day.
you might ask, why me? Well, I'm here because I'm standing up for myself. And I know that when a woman stands up for herself, she stands up for all women. And all women go through menopause. Our experiences with menopause are just as individual as we are. No 2 women go through menopause in the same way.
Some of the symptoms that I'm experiencing of menopause, I think, are the obvious ones, which are night sweats, a little bit of mood swing, a little brain fog.
Hot flashes, sleeplessness.
I'm tired all the time. If I wake up, I'm tired.
In this class, we've brought together 4 of the world's leading experts in women's health.
We're gonna talk hormones, where they come from, where they go, what they do in the body. There's good news. We can throw our tampons away.
It seems radical to talk about menopause, but it really shouldn't be radical to talk about an experience that happens to 50% of the population, right?
And it's time that we crack the code and open up the conversation on menopause, as opposed to being afraid of it.
Getting older is a gift. It's something to be excited about. It's something to look forward to. You just need to reframe it.
Like, if you think about the dominant narrative in our culture today, it's that menopause is a disorder, right? It's a disease. It's the canary in the coal mine of a body in decline, and we obsess over bodily changes in women and discount men being the norm. It's crazy, and that's why this class is so important.
It's not a disease, nor is it a condition. It's as natural and as awkward as puberty. We'll discuss the latest in hormone replacement therapy. And yes, we're gonna talk about sex. Sex only gets better when you get on the other side. This class covers everything I wish I knew about my changing body. I'm Halle Berry, and this is the magic of menopause on Masterclass. The first time I heard the word menopause was when I realized I was in perimenopause. It was when I was smack dab in it and had been in it for probably 5 years without knowing that this was the phase of life that I was in. I thought I was going crazy, that I was making up these symptoms, wondering, am I really feeling like this? Am I really having a hard time remembering things? And it was frightening. That if I had such little information, I only imagined how thousands and millions of women around the world had the same little information.
Things that you don't know about are scary, right? And that's how education is really power here. Understanding vital information about how your body works and how your reproductive system works and what you can do about it when it's not serving you in the way that you want it to serve you. I'm Dr. Jen Gunter. I'm a board-certified OBGYN and best-selling author of the Menopause Manifesto. I think a lot of people are confused about the basics even, so we could start there. What exactly is menopause? The first thing that comes up is perimenopause. This is the time from the beginning of menstrual irregularities all the way up till you're a year past, the final period. Ovulation's starting to become more chaotic. And the closer you get to your final period, the more chaotic it gets. Symptoms may go on for years.
It's like my body just stepped outside of itself, you know? I started forgetting things. I started losing things.
For some people, their worst symptoms are in the menopause transition. And some people have very few symptoms in the menopause transition. And of course, there's every permutation and combination in between. Then there is menopause. And you don't know that day has happened, though, until you're a year past.
I think I talked with my doctor, with my gynecologist, when I hadn't had my period for a full year. She was like, that's it. Welcome.
So menopause is really just a single day. And then everything that comes after that, which can be many decades of a woman's life, is the postmenopause. My name is Dr. Lori Barato. I'm a clinical psychologist specializing in sex therapy with women. I'm also a professor of obstetrics and gynecology at the University of British Columbia, and I wrote Better Sex Through Mindfulness. There certainly is a kind of prevailing narrative of menopause as disease. First of all, it's inaccurate, right? So menopause is not a disease, it's a natural state. Even just that language of it's a natural state opens up a conversation that is much more empowering. In the same way that when we talk about puberty, there's a lead up to, there's a discrete change, and then there's everything that happens after puberty. And we really need to be having the same conversation when it comes to menopause.
Hormones like estrogen and progesterone, they're released by your ovaries. And so when people think about estrogen and progesterone, these sex steroid hormones, they think reproduction. But these hormones act on almost every single cell throughout your body. My name is Emily Jacobs, and I'm a neuroscientist at the University of California, Santa Barbara, and I direct the Anna S. Bowers Women's Brain Health Initiative. Hormones are chemical messengers. They're produced by special endocrine glands that are all over your body. So your ovaries produce two big ones, estrogen and progesterone. And once those hormones get released, they travel through your bloodstream. So they use your circulatory system as their superhighway. They go everywhere your blood goes. And because of that, they can broadcast information to every cell in the body to coordinate different organ systems. They act on the nervous system, on the cardiovascular system, on the digestive system, on the skeletal system. That's the power of estrogen. This is an intimate dance between our ovaries and the rest of our body, and our bodies get used to this dance.
So in the perimenopause, we see fluctuating levels of estrogen, and that's what gives rise to many symptoms like hot flashes, night sweats, difficulty concentrating, is the fact that estrogen is moving up and down. There may be peaks of estrogen followed by a dive.
The brain and the rest of the body is changing along with it. You're not ovulating every month. Your cycles are going through a transition. It's kind of like the DJ puts on a new record, right? And all of a sudden, the beat is a little bit different. And for a few years, that beat can be a little hard to dance to. But eventually, all of these systems get used to the new normal, right? This sort of new song or new dance is established. Those symptoms are gonna subside, and you're back to grooving again.
Uncertainty can lead to mental health distress. But when you know what you're dealing with and when there's a name to what you're dealing with, then automatically that is therapeutic. The anxiety levels go down. Just knowing and naming treats your anxiety. My name is Dr. Judith Joseph. I'm a board-certified psychiatrist and researcher, chair of the Women in Medicine Initiative at Columbia University, and a board member of Let's Talk Menopause, a national nonprofit for advocacy and research in menopause. When my patients come into the office and I ask them to name how they feel, many of them will say, oh, I don't know. Yeah, I don't know what that is. But if you get into the practice of naming your emotions, of validating your experiences, then you identify it. There's something called affect labeling. If you're aware of what's happening, you're less anxious, you're less afraid, and you're more empowered. That sends a message to your brain on a deeper level that I know what I'm working with here. And when I know what I'm working with, then I can pull on tools that have worked before. That gives me a sense of agency and empowerment to deal with the situation at hand. So to decrease uncertainty and anxiety, I teach them the TIES method. TIES is an acronym for the mental health symptoms in menopause. T is thinking. These are the cognitive changes such as brain fog, forgetfulness, time management issues. The I stands for identity. A common report is that people feel like they don't know who they are anymore. The E is emotions. We know that with the menopause transition, people may have symptoms of anxiety and depression, irritability and mood swings. And the S stands for sleep. Insomnia and problems falling asleep, staying asleep. No pun intended, sleep ties it all together. And if you have poor sleep, you're gonna have poor mood, you're gonna have low energy, you don't think as well. And sleep is disrupted with age, but even more disrupted when you go through the menopause transition. Knowing the ties and knowing what to expect is empowering because then you have a way to address the ties.
The years before I realized that I was in perimenopause was one of the most confusing times of my life. I was turning into somebody that I knew I wasn't, but I had no explanation as to why. There was loneliness associated with it because I couldn't talk about it with anybody because I didn't even know what to talk about. When I found out that there was this thing called perimenopause and that all of these symptoms were part of this time of life, and I got assurance that this is just this sort of passing through moment, I had great relief. Of course you're gonna feel anxious when you're having all of these bodily changes and you're not sleeping and you're tired and you can't remember things and you're sweating profusely and you go, holy wow, like what is wrong with me? What is wrong with me? So, you know, it's a journey.
I think I started going through it at about 48. And first, I just stopped having my period. And then I had one, and that was weird. And then the hot flashes started. And I said, oh, this is real menopause. This is the real thing.
In North America, with some variation, the average age of menopause, that single day, is 51. Perimenopause can be up to 10 years. And that means that perimenopausal symptoms can start at 41. So suddenly that 30-year-old, 41 is right around the corner. There is some data that shows that a mother's age of menopause can predict a daughter's age of menopause with some variability around it. I only recently, as an almost 50-year-old woman, asked my mother at what age she reached menopause, and she said, sometime in my 50s, which was not helpful.
I think a lot of people have been led to falsely believe that symptoms shouldn't happen until your last period. But many, many people have symptoms before. The very first sign of the menopause transition that we use in studies is a change in your menstruation. So changes in the heaviness of flow. Some people may have lighter flow. Some people might just start to notice heavier flow. And once you start to notice a change in the length of your menstrual cycle, so maybe you're going from 28 days to 38 days, then 28 days to 35 days. So you're having these changes of 7 or more days. We would say that you're in the early menopause transition. And when you're going 60 days between periods, then we would say you're likely in the late menopause transition. So this is when it's important to know about symptoms. Some of the cardinal symptoms of menopause would be hot flashes, night sweats, sleep disturbance, depression, mood changes, anxiety, joint pain. Brain fog is a symptom. If those things are happening to you, then that's also a time to come in and discuss it.
The hot flashes were like frequent. They felt like they were coming on like every 3 minutes.
The kicker was when I started losing my hair. Girl, I already ain't got no hair. I don't have time to be putting on no wig.
And then the facial hair. Like, where did I start getting hair underneath my chin? I was like, oh no.
Sometimes I'd be like, just get away from me. I don't even want to talk to nobody. I don't even want to hear it. Just go away.
I thought, oh, lucky me. I haven't had any hot flashes. I didn't feel any changes. Oh, I'm killing it at this. And then about 2 years in, boom.
Now, if you're on an estrogen-containing birth control pill, you may not have as many of those symptoms because you're getting some estrogen, but you might, depending on which one you're on and your individual physiology. So that's peri, is encompassing that, am I not, am I there? What I like to call the great menstrual weight.
Don't get a good night's sleep anymore. I'm tired all the time. I have talked to my daughter on the phone multiple times. And I was talking to her on video chat, holding the phone right in my doggone face, holding the phone in my face, talking to my daughter, looking at the phone, saying, have you seen my phone? I don't know where my phone is at. It's somewhere around here. I thought I had set it on the couch somewhere. She said, Mom. She just kept saying, Mom. And the whole time she was saying, Mom, I heard her saying, Mom, but I was on the quest, I was on the mission. I needed to find my phone. She stopped and she said, Nicole, you are on the phone. What is wrong with you? And I was like, I don't know. I laughed about it. And then I started crying. I thought something was wrong. And she thought something was wrong. She was like, Mom, I think you need to go see the doctor. I thought I had dementia. I thought that I was going through early stages of dementia. And I got really scared because I was thinking, what is about to happen with my life?
Menopause can be very confusing. Some of the symptoms during the menopause transition can mimic things like depression and anxiety, and even ADHD and dementia. So having a psychiatrist on board as a part of the team can be very helpful in determining what's causing the symptoms. A lot of people will experience symptoms of depression and anxiety, but they will not meet diagnostic criteria for a major depressive disorder, for a generalized anxiety disorder. So the treatment's gonna be different. The 3 Ps is very helpful when you're trying to determine whether or not your symptoms are due to depression or if they're due to menopause. The first P is your period. If you are having period changes, then you're likely experiencing symptoms due to menopause. The second P is physical changes. Under the DSM-5 criteria for major depressive disorder, there are no physical changes. You're not going to see hot flashes. You're not going to see skin changes. And the last P, this is very important, is the past. If you have a past history of depression, then you need to be concerned about a recurrence in midlife, because people with a past history of depression or a past history of trauma, past anxiety, are more likely to experience the mood issues recurring in midlife because it's a vulnerable position. It's a vulnerable time in life when your hormones are changing, so you're more likely to have another recurrence. So using the 3 Ps, you come armed. You know what you're dealing with. You have less stress, you make better decisions.
It started with really low energy, like lethargic almost, like convincing myself to get out of bed. So that's when my doctor started questioning if it was depression. So I tried all sorts of different medications for depression, like so many different medications, but it's like these symptoms were still like overwhelming me. And I was like, I know, I'm definitely perimenopausal.
I teach my clients to listen to themselves, to validate their concerns, and to be their biggest advocate and historian. And when you go to a doctor's office, there are things that you should know. What is my medical history? What is my family history? What are my symptoms? How long have they been going on? When you become the expert in your own history, that is empowering, but it also helps your clinicians to know what they're dealing with.
I would say get a symptom tracker, whether it's a notebook, a diary, an app on your phone. You know, start to track what you're actually feeling so that when you do go to your healthcare professional, you can be clear about what you've been feeling, times of day, you know, when do these symptoms arise? Be as clear as you can with your doctor so that you can really talk about it in very substantial terms.
And I encourage my clients to make their own biopsychosocial model. The biopsychosocial model is used throughout all of medicine. And when you look at your symptoms, try to think about things in terms of this model. So you want to draw or digitally create a Venn diagram with 3 overlapping circles, and then designate each circle to represent biological, psychological, or social factors. The biology part looks at things like genetics. It looks at your background, your ethnicity, your medical history, medications. Then you look at the psycho part, your past psychiatric history, you know, your baseline resilience, your baseline coping mechanisms. And then looking at the social model, your work stress, your relationships. Now you'll see some overlap on this biopsychosocial model because some of the social behaviors overlap with the biology, right? If you are using things excessively like substances, or if you smoke or drink, start to write down your habits. Look at experiences that can be potentially traumatizing. Is your work toxic? Are your relationships not healthy? This model can be very helpful when looking at your symptoms because they can impact your symptom severity. So knowing these areas and these components gives you knowledge and the power to focus on things that you can change, that you can modify.
So when I'm starting to have the menopause symptoms, a lot of things come to mind. Can I control it? How long will this last? Is this gonna affect me? Do I need to step away? Do I need to clear my mind? So in my mind, I like to correlate it with other things that are happening around me because maybe some of the symptoms are triggered by what I'm doing or what I'm eating. Is it after alcohol? Am I anxious? So I try to figure out what that is.
So to understand menopause, we sort of have to go back and think about what happens during our menstrual cycle. So when estrogen levels surge, your brain changes a little bit. In fact, if we do specialized scans of your brain and we zoom into an area called the hippocampus, you can see this region of the brain literally get bigger, right? So this brain region is sort of pulsing when estrogen levels go up, and then it sort of returns to baseline when estrogen levels go down. That pattern happens during the reproductive years. If we're kind of thinking about what areas of the brain in particular are responsive to steroid hormones, it's the hippocampus and another region of your brain called the prefrontal cortex. So it's the area right behind your forehead. These together are systems that play a role in learning and memory. And it's one of the reasons that when women go through perimenopause, you might experience some temporary brain fog because these are the systems of the brain that are trying to figure out the new normal.
I had to give over to this new way of acting. Well, I'm gonna wing it. I'm gonna improv it if I can't remember it. There are times when we had to say cut because I went totally blank and just forgot, what are we talking about? What is this scene actually about? And that's terrifying. Like, it's terrifying to feel that way.
You think, is this it? Have I just lost my ability to find words? Am I gonna be struggling to, remember where my keys are forever? Is this feeling of brain fog gonna affect my efficacy at work? It is terrifying until you realize that it's incredibly common, it's transient, and it's not a sign of anything deeper. This is normal. Brains are built to change, they're meant to change. They change during puberty, they change during pregnancy, and they change during menopause. That's a feature of our biology. If we bring you in and have you do challenging tests in the lab to look at brain function, there's only like a few very specific areas that we might see some change over menopause. These tend to be in the domain of verbal memory. So things like a list learning task. Like if you write down a grocery list and you try to memorize it and go to the store, that sort of verbal memory declines across menopause. It does, it declines. But here's the backstory to this. Females have this advantage in verbal memory. It starts around puberty and it ends around menopause. So for about 35 years of our life, women outperform men on these verbal memory tasks. This is a super solid finding. We can see it across populations. There's just a verbal memory advantage. And when you go through menopause, you lose that advantage. So you're kind of just declining to the level of a man. We might put you in an MRI and look at your brain as you're performing some challenging memory task. And rarely do we find what we call like objective cognitive differences between a postmenopausal woman and an age-matched man. They're performing neck and neck, but we might see differences in the strategy that their brain uses to get to the same place. So for example, maybe in the postmenopausal woman, her frontal lobe is more active. Maybe she recruits other parts of her brain to help her get the job done. It's not the strategy that her brain used 10 years ago, but it's the strategy that her brain can adopt to achieve the same outcome. Your brain isn't going backwards, it's evolving forwards. But ultimately, there are options that we can think about that can help mitigate some of those symptoms.
It's important to know that with thinking issues and cognitive issues, you can do simple things right now to ease your symptoms. Decluttering has been very powerful in terms of de-stressing your environment, making things simple so that you can save time. Using things like organizational skills therapy that's traditionally used for ADHD, applying that to your experiences today can be helpful. Things like using a launch pad, an area of your home where you put your keys, your wallet, the typical things that you spend a lot of time looking for, keep them in the same place every day. Also, making lists to prioritize. Many times we want to do a million things at once, but validate that you can't continue doing that, you will burn out. So simplify your routine and focus on the most important things in the present moment. And that way you're not overextending yourself and overwhelmed.
One of the, I think, really tricky things about perimenopausal symptoms is that there's not a particular order in which a symptom may start, right? So for some women, there may be brain fog, whereas for the next woman, she might notice hot flashes.
I was working on a movie recently and the sweats came on, the hot flash came on. And I chose in that moment as the character, rather than saying, cut, I'm sweating, I just accepted the character is sweating right now. And so if I stayed true to my character and be alive in the moment, which is what good acting is all about, I just used that and I start stripping off things, right? Because that was real for me in the moment.
So about 80% of women feel what are called vasomotor symptoms. So these are hot flashes and night sweats. And you feel them in your body, right? You feel them in your face and in your neck, and your chest starts to get really hot.
If I were traveling, if I were flying somewhere, and all of a sudden being in a full body sweat, now I have to take off everything. I have to take off my sweater, trying to do it and not knock into people. I found that kind of embarrassing.
I was hanging out with one of my girlfriends. In the middle of us talking, it was a million beads of water all over her face.
The control of it, that is the worst part of it for me.
Hold on one second.
Just in that way where I don't know what's gonna happen on any given day at any given time.
I had somebody tell me, girl, just Just think cool thoughts. And I just looked at her like, Ma, come on. You can't tell me just think cool thoughts.
At night, you kick off the sheets because you're getting this kind of full body response, right? But even though you feel it in your body, the signal for initiating a hot flash actually comes from your brain. And it comes from heat-sensing neurons that are in your hypothalamus. So this is a region of your brain that has something to do with temperature regulation. And this circuit in your brain is used to getting signals from estrogen and progesterone. And then when you start to go through perimenopause and your cycles start to change, that signal from estrogen and progesterone isn't as reliable as it was before. And so these neurons start to misfire a little bit. These are called neurokinin neurons that are in your hypothalamus. They start to misfire, and that misfiring we feel as a hot flash. That basic science of understanding this temperature regulating circuit in the brain, understanding that basic biology led scientists to the development of a new drug. This is a non-hormonal drug called Veozah, and it essentially stops those neurons from misfiring. By the time estrogen and progesterone levels stabilize in the post-menopausal period, the brain gets used to this new normal.
Currently, I'm on Veozah. It's very expensive. So thank you, Obamacare, for hooking a sister up, because there's no way I would have been able to spend a good $900 a month on this just so I'm not waking up in a pool of sweat. It definitely helped with the hot flashes and the night sweats, but the energy is still low. So I'm hoping to find something that will help with that.
There are lots of options for a variety of different symptoms in menopause. Estrogen is the gold standard, especially with hot flashes specifically.
I don't know much about hormone replacement therapy other than I know the acronym for it and that it's supposed to help people.
What I've heard about HRT is that it can cause breast cancer, and I don't want cancer.
I was like, I think I need to start HRT. And my doctor, she was like, well, there's been studies that have attached it to breast cancer. And I was like, okay, well, now I gotta go back online on WebMD and I gotta look up, like, you know.
So the risk that a lot of people get worried about is the risk of breast cancer. And this is for people taking combination therapy, an estrogen plus a progestogen. That risk is about 1 in 1,000 per year. Now, to put that 1 in 1,000 in perspective, that's about the same risk as the risk of breast cancer from being obese. That's about the same risk of breast cancer from having a glass of alcohol a day. And if you're using Premarin only, which is conjugated equine estrogen, your risk of breast cancer is actually lower. But a lot of people come in with preconceived notions that this might be a super risky thing because of things they've read in the news or other things.
Still all right?
Fears about HRT have centered on the possibility that it might cause cancer.
It's very confusing, very difficult decision to make.
Some doctors are advising women who are using combined HRT to stop.
Newsweek calls the response like near panic. Women essentially flush their pills down this toilet. They stop taking hormone therapy overnight. But there were two big problems. The first problem is that those articles didn't get into the difference between statistical significance and clinical significance. They didn't talk about the fact that if you double a really small number, it's still a really small number. The other issue was about the way the study was designed. Most of the women in this trial were in their 60s and 70s, up to the age of 79. And when researchers went back and reanalyzed the data and just focused on the women who were in their 50s, it was a completely different story. The young women in the trial who received either the combined arm or the estrogen-only arm had lower rates of breast cancer. They had reduced risk of cardiovascular disease. They had lower rates of all-cause mortality, meaning death for any reason, and there was no difference in the rate of dementia. That story wasn't reported by the media.
And I always like to say, you know, we hear about breast cancer risk all the time with hormones, or it seems to be, but we never hear about risks like blindness with drugs for erectile dysfunction. But, you know, those do exist, again, albeit rare. But scaring men about their bodies doesn't seem to get attention, and scaring women about their bodies does.
And that fear is unfounded if you are a woman who is going on menopausal hormone therapy early in the transition. We just want to make sure that women are not relying on outdated news stories that make them fearful of something that could be an option for them.
But not everybody can take it. Not everybody feels good on it. And everybody's risk is different. Some people have personal reasons they don't want to take it. And so I think it's important to hold space for all of those options.
There are some medical interventions that you can use, but, you know, I'm really into the natural remedies. I have a friend that told me about taking a baby's teething ring and putting it in the freezer. And then if you start getting hot, just put it on your ears, get 2 of them, put them on your ears just to cool you down. I've had some folks say get some ice cubes and put them in special places to cool you down. I don't know if that'll get cut, but it's just one of the tips I heard about. And it works. So anyway.
So there are non-hormonal options for hot flashes. There are neurokinin 3 inhibitors, and well, there's one currently on the market, but this is a real active area of research, so it's really exciting. I think we're gonna see more drugs in this area. There are also studies that show that antidepressants can be useful. For example, paroxetine or venlafaxine, those can be very effective. Then gabapentin is another medication that can be used, and pregabalin can be used as well. And oxybutynin, which is a medication actually we use often for the bladder, can be used. And so these are a variety of other options. And of course, there's also cognitive behavioral therapy, which has actually been shown in good quality studies to be effective for treating hot flashes.
So that's one type of therapeutic modality. There's a newer type of behavioral therapy, metacognition. Metacognitive therapy is a form of cognitive behavioral therapy, but it focuses less on changing the thoughts. It's really teaching you how to think about your thinking differently. So this can be very confusing. And I highly suggest that you work with a therapist who is trained in MCT. If you tell someone to stop thinking about an elephant, the first thing that they're gonna think about is the elephant. MCT is allowing the elephant to be and just not giving the elephant as much of a platform. So you know the elephant's in the room, but you're making a choice to focus on other things, right? It's not to say that that hot flash isn't happening. It's still happening, but you're not putting as much emphasis on it. And that may help to decrease the length of the hot flash and also the repercussions of the hot flash.
Many people who think they're sleeping well in menopause actually aren't. And I always give my own example. So I am a super flasher. They're controlled now, but sometimes I can have them at night still, and they're bad enough that they wake up my husband, but they don't wake me up, right? I'm still obviously having them. I'm objectively experiencing them because my skin is hot. And almost certainly my sleep is probably being disturbed, but I'm not disturbed enough that I wake up, right? So sometimes people can be having sleep problems that they don't realize they're having them because they're not waking up, but there may be some things still going on biologically that could be affecting the quality of their sleep.
As neuroscientists, we care a lot about sleep because sleep quality is really important for your brain. If you are having hot flashes, especially at night, that leads to disrupted sleep, and disrupted sleep is going to lead to brain fog. There's a reason that some regimes use sleep deprivation as a form of torture. It's because it is murderous on the body.
I would say menopause affects my career. I'm an entrepreneur. I'm interacting with people all the time. So I could be in a mood where I couldn't sleep the night before. So I'm already annoyed because now I have to get up and I still have to be in my appointments, right? So the insomnia can affect me in that way, where I'm moody, I've only had 3 hours of sleep, or I've been in and out, up and down, or I'm just awake. And that affects my mood, right? You know, I could be a little bit more snappy or a little bit more anxious or, you know, a little more disengaged. And I don't want to be that way.
Mood changes can affect sleep, but sleep can affect mood, right? And so we have to think about, well, which came first, the chicken or the egg, or is it both? And maybe we need to approach both. And there may be situations where someone is not sleeping well because they're having multiple hot flashes a night. And so we might say, well, we want to get some estrogen started to see if we can get you sleeping better and to see if that has an impact on your mood. And then we might want to reassess that in 6 to 8 weeks. And we may not need to have that discussion because once someone is sleeping better, things might be better. But again, there are some people who don't want to use a medication, and I really believe we have to meet people where they are and have as many options as possible.
Recently, I got this mattress, and it's a cooling mattress. Changed my life, because now I don't have to sweat through the nights when I have like cool air emanating from underneath me. And so I'm getting a better sleep.
But if you're experiencing sleep disruption because you're stressed at work, or you have a kid in college and there's financial stress, right? Like there's all sorts of reasons why by the time you hit midlife, shit gets real. And that's not just because you're experiencing these symptoms of menopause. So one thing that a good provider would do is try to get to the root of those problems. They're gonna point you to different options for trying to preserve and maintain good sleep habits.
There are other non-medical ways to address sleep. For example, the bedroom should only be used for sleep and intimacy and nothing else. And if we condition our brains to view the bedroom as a place just for sleep and intimacy, then that helps us tremendously. Sleep hygiene entails things like keeping the bedroom cool, things like keeping light at a minimum. So I joke because I travel a lot for work and I call myself the light hunter. Every time I go to a hotel, I'll find some tape and I'll start taping up these little lights around the room because even a little bit of light can disrupt your natural melatonin, the natural circadian system in your brain that controls your sleep-wake cycle. Also, decreasing the amount of caffeine intake, sugar intake, greasy foods, those will all help you to get better sleep. There are other things people can use, like using worry journals. A lot of times, we don't process our stress and our worry during the day, and what happens is that it'll pop up in the middle of your sleep. So a lot of people wake up with anxiety at nighttime because they haven't processed their worries. So I would encourage you to keep a worry journal and set aside time in the day to worry. So you pick the time of the day, and it should be the same every single day. And pick the location. It shouldn't be a place in your home where you spend a lot of time, because you want to associate that location with the worry. That's a worry corner. Pick that time and that place. Usually it's 20 minutes, that's your time to worry. Get it all out. But once you leave that corner, that's when you focus on other things. That's a skill and a tool that you can use for the rest of your life.
And menopause is a great time to step back and reflect and say, how is everything that's going on in my personal universe affecting me? How much of this is my lack of sleep from hot flashes? How much of this is the fact that I'm having depression from the menopause transition? So that's affecting my ability to be able to be motivated to go outside for a walk. It's all very complicated. And it's really difficult to sort out a complicated thing in a 15-minute office visit.
So GSM is the genitourinary syndrome of menopause. In the past, it used to be called vulvovaginal atrophy. The most common symptom of GSM is vaginal dryness. There might also be urinary changes like UTIs or urinary tract infections, urinary incontinence or leakage that happens, and that can be incredibly embarrassing for women. But the reality is between 50 to 70% of women have GSM. And we're much more likely to talk about a hot flash or a night sweat than we are to say to our doctor, doc, sex hurts, and I don't know what's going on.
You know, one doctor who I love, who was a very good doctor, told me that I had herpes. And when it was all said and done, it wasn't herpes at all. It was the drying that happens to all of our orifice of our body. Not every woman experiences that, but that's what I experienced. Dry eyes, dry mouth, and dry vagina. And that was never explained to me. I was 54 years old when this was explained to me. I've since learned that should have been explained to me when I was 40, that this is a possibility. So here are some things you can do along the way so that you won't get to the place where you feel like you have razor blades in your vagina and you're running to the hospital and you're wondering what the heck is going on.
GSM has been studied quite a bit when it comes to understanding menopausal and perimenopausal symptoms. And it's also been an area where, thankfully, there's been a lot of good research on hormonal treatments for it.
But if for whatever reason you have a contraindication for taking a systemic hormone therapy, meaning, you know, taking a pill, there's topical creams, estrogen cream, that can help with vaginal dryness, and it's safe and effective for almost every woman on the planet.
When I did talk with my doctor about it was when I was getting an annual, my pap smear, and that was super painful. And so that's what brought it up, was like, wow, this procedure, which is never comfortable to begin with, was super painful. So I'm using estrogen cream now, partly because if and when I have sex again, I want it to be pleasurable, but also because I want these exams that I get to not hurt so much.
For some women, it's like, yeah, I never used a lubricant at any point in my life, and now my vagina is dry. It makes vaginal insertion painful. In fact, there's so much pain that I've lost my desire. I'm avoiding sex. I'm avoiding undressing in front of a partner. I don't engage in foreplay. Really, really common, and I sort of kind of portray that out because it's more than just dry vagina, right? It can have an impact on intimacy across the board. It's actually a core part of quality of life.
My sex drive has not decreased, but I believe, like, I can't do, okay. I'm not gonna say what I was about to say. Okay, so it's just different now.
When I did have sex, it was painful.
The dryness, it gets embarrassing, you know?
As a sex therapist and a sex educator, I normalize the conversation about lubricants. In fact, I equate it with using an alarm clock, right? So I use an alarm clock in the morning to make sure that I wake up at the time that I would like to wake up. Yes, I could wake up naturally, but it's so much more reliable to rely on an alarm clock. Over 60% of females across ages are using a lubricant. Lubricant is not about treating a dry vagina. It's about making vaginal insertion and vulvar stimulation more comfortable, more pleasurable, right? More enjoyable. Thankfully, we don't need to go into any store to buy lubricants. You can buy lubricants online pretty quickly. A vulvar or clitoral lubricant allows one to experience arousal and pleasure in a more reliable and efficient way than, quote, waiting for it to happen. So if we can normalize it in this kind of way, then yes, it means that the young person at their very first sexual encounters is talking about a lubricant, is making it sexy and fun, and equips that person for having maybe more challenging conversations about their sexual needs later on in life.
I think a really important component to women embracing this time of their life is finding a way to incorporate their significant others. I think men and partners have to really be a part of this conversation. It's not just a female problem or our problem. It's an issue that we all have to tackle together.
One of the ways that I often encourage women who might be a little bit embarrassed to bring, like, how do I bring this up? I've been with my partner for 35 years and I don't know what words to use. You can say, hey, I listened to a really great episode on a podcast, or I watched a masterclass on sexual health and menopause. And could we start to explore this? Sexual communication is the ability to say, I feel most sexually satisfied when we do this. And I focus language is a really important tactic to use, especially in the context of a relationship. Because if I can say to you, you know, I really enjoy it when my labia are stimulated, that's received very differently than you're not touching me the right way, or you're not finding the places that elicit pleasure for me. So being able to kind of own the locus of control helps also eliminate any chance of defensiveness on the other person. It also just communicates to yourself that actually my sexuality is mine. I own my sexuality. Sexual communication can also be the ability to talk to a healthcare provider when there's pain with sex, when there's been a change in your desire for sexual activity, when orgasms don't feel as pleasurable as they used to. So essentially, we're talking about sex. That's sexual communication. If you're able to talk about sex, you're also more likely to access resources for sexual health. You're more likely to separate fact from fiction. So sexual communication doesn't exist in a vacuum, but it can be such an important predictor of who's going to have sexual satisfaction in the long term or not.
My husband and I were very honest about sex. We are rocking right now. Because the kids have gone to college, we've been having a blast. So thankfully, it's all working for me.
I don't think it's the end of my sex life, but I think when I do have a partner, I would have to be a little more proactive in getting my libido up. Yeah, now I have absolutely no desire, but hopefully I'll recover.
So when we think of desire and libido, we kind of think about it in only one way. You feel horny or you don't. You have that kind of wanting, that lustful feeling deep in your belly, or you don't. And unfortunately, first of all, it's not accurate. A lot of science has debunked that there exists just one kind of desire, which is really great news. But the other harm that it leads to is this belief that once it's gone, once it is gone, you can never get it back. Again, totally debunked by the science, thankfully. So to the men who are watching, this is a fantastic time to talk about sexual desire. Yes, there might be that spontaneous, out of the blue, I feel horny, but that kind of desire will decrease, not just with menopause, but just in any long-term relationship. Thankfully, there's a second kind of desire, and it's a much more common kind of desire that emerges in response to a sexual encounter. It can be very normal to go into a sexual encounter even without a libido, because what we now know with this kind of responsive desire is that if we go into an encounter with a reason, with an intention, if we're using triggers and stimuli that work for us, and then really importantly, if we pay attention, if our mind is in the moment and not pulled away thinking about a multitude of other things, then that paves the way to arousal and responsive desire. And so now suddenly she says, now I feel it. Now I want this. This feels great. I'm motivated. I'm in sync, and I want this to continue. I think another really important takeaway, no matter what it looks like, no matter how frequent, no matter the intensity of pleasure, we can learn to enjoy sex and feel pleasure well into the older years, it's really important to believe and accept that sexual health is part of health.
So there's the tire in the middle. There's this tire, I call it, that just shows up around your midsection. And I've never had a tire around my midsection. Never thought I would. But when old Perry came knocking at my door, this tire showed up out of nowhere. Also, very confusing. You can't understand why. You think, I'm eating the same way I always used to eat. And then this happened. Everything about our body composition starts to change. And this midsection weight gain is just part of it.
The weight gain is real. I couldn't lose a pound anymore. Like, I used to be super thin and that great body, but menopause changed a lot of that. So that's also been difficult because it will affect your mind because you don't recognize yourself. So I have what I call reverse dysmorphia. When I see myself, I think I look in my head, I think I'm thinner than what I am. It's not until I see pictures. And then I'm like, who's that? Oh, that's me.
So some women say, I gained 5 or 10 pounds when I went through menopause. First of all, everyone gains weight as they get older. That's just a normal part of the aging process. But a cool thing about the body is that that actually might be your body saying, hey, I got another source of estrogenicity for you. There are other systems that can kick on estrogen. So you have adipose tissue, fat, and those adipose cells can produce a hormone that acts like estrogen in the brain. And it's a way of keeping your brain healthy. It's kind of taking the load off your ovaries, and here our brains are able to benefit from that extra estrogen. So yeah, you may feel a little bit heavier, but it's actually your body's way of keeping your brain healthy.
Hormonal changes during the menopause transition may cause the fat deposits to crowd around your belly area. We don't exactly know why that is, but doctors will tell you that belly fat can set you up for things like metabolic syndrome, diabetes. But there are things that you can do about this. It's not that easy, and sometimes you do need to work with a nutritionist, but food really is medicine in this case. The majority of the deposits are related to nutrition, and many of us are not aware that the foods that we're eating are highly processed. If you look at the ingredients on the back of what you're eating and you can't pronounce it, it's likely processed, and it's increasing inflammation and worsening your physical health. Changing your diet so that you're focusing on foods that are high in fiber, that are high in protein, that are more nutritious, less processed, less sugary, all help because they reduce inflammation and can change the way that fat is stored in your body.
Then there are these other symptoms like joint pain, and menopause is also associated with a higher risk of osteoporosis. It's a disease of bone health and causes bone fragility.
I think that's where my journey really started with this, was that what is going on with my hips? It's so weird. And the more conversations I had with women about their hips, we all seem to be having that same thing. So you got this hitch in your giddy up, you stand up and you're like, and you fall over and you're like, oh my God, I'm literally falling apart.
We care about osteoporosis and also osteopenia, which is sort of the lead up to it, because they increase the risk of fracture, and fracture leads to all kinds of awful complications. Estrogen is really important in building bone. It helps build bone. And so when we lose estrogen, we stop building bone. And this is important because not only are we always building bone, but we're always losing bone. It's kind of being recycled. So if you're affecting that equation in that you're not changing the loss part, but you're affecting how much you're kind of building, you're going to start to get this loss of bone. And It differs really for different women. Some women can have a pretty significant loss of bone during their menopause transition. It tends to start about 1 or 2 years before the periods end. And other people don't have much loss at all. But also, some people come into menopause with a much higher bone bank than other people. So if you've been a lifetime smoker, if you're someone who didn't have periods for 2 or 3 years, if you're somebody who maybe had a significant nutritional deficiency, you might not come into menopause with a bone bank. So we want to ask you about risk factors. We also want to know about genetics, family history. And we want to try to calculate then to see, are you at somebody at higher risk for osteoporosis, or you're somebody at lower risk, and then make decisions based on that. And for people who have concerns about osteoporosis, menopausal hormone therapy is a very good preventative tool. My own mother died from osteoporosis. People don't think about dying from osteoporosis. They think about, oh, well, maybe have a break. But breaks can lead to not only pain and suffering, but sometimes they can start a chain of terrible events. And that might cause someone to go from living independently to have to live in an assisted living facility. That might lead to someone having a terrible life of chronic pain, where then they have other complications, maybe related to medications they have to take for that. All kinds of awful permutations and combinations. And there are other medications that can also help prevent bone loss, and that's important for people to know, because not everybody can take menopausal hormone therapy. Now, if you have a concern about your bone health and you want to take it for that reason, it's very valid. But if you say, well, I only want to take it if I need it, right? Then we want to look at what your individual risk factors are, and there are a couple of different tools. There is something called the OST, and there's another scoring system called FRAX, F-R-A-X. And those are both easy to look up online, and you can put your data in and try to start to assess whether you're at higher risk or lower risk for osteoporosis. And people who are at higher risk then should probably consider having their bone density checked. One of the things I think that's great about menopause is that we start talking about health in ways that are encompassing. But one of the bad things is we should be talking about your bone health when you're 20, right? Because you're building your bone as a teenager up until about the age of 28 or so. You're building that bone bank. So it's important to you through your whole lifespan. You always want to be thinking about your bone health, weight-bearing exercises, so important, resistance training, and there are many things that can also be done from that standpoint, right? So protecting your bones isn't just about taking estrogen. It isn't just about taking an anti-resorptive medication or whatever other medication that might be useful for osteoporosis. It's also about making sure you're getting enough calcium, making sure you're getting enough vitamin D, making sure you're getting that resistance training, working on your balance. Because if you fall, that's how you break a hip. You don't break a hip sitting, right? So you also have to think about all of these things that go into fragility and health and how they're all important. That's why resistance training is so important for women. And if I could change one thing, would be to have resistance training taught early, because I came to it very late in life, and learning about how important it is for your bone health and muscle health and brain health and everything else. I'm doing it now. It's never too late. That's the great thing about it. But that's why I say if you're thinking about your bone health, today is the best day to start.
I've worked out my entire life. It's been a part of managing my diabetes, and it hasn't always been for the physical aesthetic. It's really been for optimum good health, but the physical is a part of that when you're really taking care of yourself from the inside out. So I realized, though, as I reached perimenopause, that I had to change my workout. It was now more about lifting weights. I didn't used to lift weights before. But as I realized I'm going down the path of life, I like to call it, I realized I have to start lifting weights now, because keeping my muscular and my skeletal self strong is really, really important. The stronger I am, the less accidents I have. If you fall down and hurt yourself at this time of life, it can be debilitating. So I've had to realize it's about upping the calories, the protein that I eat, and it's heavier weights. My body needs that just to maintain the structure that I used to have.
The mind-body connection is so real in menopause. There are studies that show that if you have baseline anxiety, if you have baseline depression, your perception of your symptoms may change based on your anxiety and your depression. So having this mind bias towards your symptoms and thinking that your symptoms are worse than they actually are can actually set you up for worse symptoms in the future. On the flip side, having new symptoms like hot flashes, problems with sleep, changes in your body, that can in turn worsen your mood, cause some symptoms of depression and anxiety. So the mind-body connection goes both ways. It's important to know how to regulate your mood, to address your depression and your anxiety at the same time as addressing your symptoms, because your perception as to how bad the symptoms are can be impacted by your initial emotional state. You just need to reframe it. And that's what I do as a therapist. I reframe. A lot of the studies show that cognitive behavioral therapy to support the depression and anxiety symptoms in menopause is very beneficial. And in some cases, more beneficial than medications. Cognitive behavioral therapy helps you to look at your thoughts differently, to change your thinking so that you have a better outcome. Many times, you may be thinking, okay, I'm aging, I'm getting older, things are happening to my body. This means I won't be able to do the things that I love. These are automatic negative thoughts that can be quite destructive, and they can put you in your place and keep you stagnant. However, if you can learn to challenge these thoughts and change these thoughts, the goal is to change them so that your feelings change and your behaviors change. There are studies that show that the way that you perceive aging, the way that you approach aging, will change your outcome significantly. If you are optimistic about aging and getting older, if you're looking forward to it, you're gonna have less symptoms. So reframing the way that you approach aging is so beneficial because you can actually age happier and continue doing the things that you love with less symptoms if you reframe.
Recently, I went to a doctor's appointment and I was having a hard time seeing. I started to have these white flashes that were continuing to sort of make their way into my sight. And so I went to see my doctor about it, and he said, yeah, well, your glands are starting to dry up, and we don't want that to happen. And I said, because I had done so much research on my own, I said, and why is this happening? And he was like, well, you know. And I said, no, tell me, doc, why is this happening? And he said, well, it's because, it's because you just got to get the treatments. Your glands are drying up. And I said, but why is this happening? And I realized that he couldn't say it. So I took the liberties of saying it for him. And I said, is it because I'm in menopause? And he said, yes, thank God you said it, because I could have never said that to you. I mean, look at you. I can't tell you you're in menopause. My female patients don't want to hear they're in menopause. They're going to punch me. And I thought, poor guy. He can't even talk to me about it because he can't say the word. He doesn't think he has permission to say the word. That's how stigmatized it is. And in that moment, I realized if our healthcare professionals are too afraid to say it, how are they going to provide us with optimum healthcare? So I think that's the goal, to make it an easy conversation to have, sort of destigmatize what this time of our life is all about.
The word menopause makes people uncomfortable. It's a fear of being judged that, oh, that means you're old. It's literally goes to, the word menopause equals old.
I saw a convention kind of like that a nonprofit agency was having, and I said, oh, this is about menopause. I'm not doing anything. I don't really need to know about menopause. I'm not even old yet.
I think it's strange to bring it up because the reality of, am I at that age yet? Like, is this really happening to me right now? Am I really this old?
There's a lot we don't know about menopause, and because we don't talk about it, we're left with myths and stereotypes. And so the typical trope or stereotype is the old lady.
The image of the menopausal woman is not one that is sensual, that is attractive.
And unfortunately, it's never challenged, and lots of myths get perpetuated. One that really taps into this conversation we're having about menopause is that sex gets worse with age for women. In fact, what the data suggest is that women are more likely to have more and more pleasurable orgasms with age. Orgasm has a lot more to do with skill and communication and comfort than it does with hormones. Myths that we all carry are so pernicious because we rarely stop to question them. And yet the beliefs that we carry impact everything, how we feel, our emotions, our behavior, the stress we carry in our body. And so it also means that we need to pause and question our own beliefs. We need to say, okay, I've been holding on to this belief about something. Is that accurate? As science is evolving, we have data that now allows us to answer questions, to be able to say, well, that actually is a myth, and we need to replace that with a fact until the next bit of science comes along. If we look back to the late 1800s, where all of women's health conditions were chalked up to hysteria, the wandering uterus, the uterus was thought to move around the body and give rise to symptoms like neuroticism, which we now know today is anxiety, or chronic pain, or abnormal bleeding. And at the time, it was thought that hysteria was the root cause. And of course, the treatment for hysteria was orgasms that were elicited by a male physician. And so we can look back now at our history of women's health and say, well, that's quite silly. First of all, the uterus doesn't dislodge and move around. And secondly, although orgasms are fantastic, they're not a treatment for every women's health ailment. But there has been a legacy of that has persisted and has clouded our teaching of women's health, what appears in textbooks, what gets discussed in the media, that still continues to this day.
We talk a lot about menopause and how women go through this endocrine transition, but men go through a similar hormonal transition. It's called andropause. Men start to lose testosterone beginning in their 30s. There's sort of a steady decline, and it continues until death. It just happens. It's just a normal part of the aging process.
But interestingly, there's been such not only a cloak of silence, but a cloak of shame, because menopause is also associated with aging, and that's something women aren't allowed to do.
Most of what we know about health and disease centers on the male body. So in what's called preclinical research, so all of the biomedical research that happens in animal models, that is mostly happening in males. Male rats, male mice. It's true in neuroscience, immunology, cancer biology, physiology, all of these fields.
When I started doing research, I was a young student, a junior scientist. I was interested in understanding the factors that impact sexual activity. And so I began to volunteer in a research lab that was using the male rat as a model of human sexuality. And so we would inject the rats with different things like antidepressants. We would expose the rats to stressful environments by crowding them in a small cage, and then measuring sexual activity. So I would watch the rats in the cage. How often did they mount? How long did it take them to ejaculate? And I spent many, many years doing that. Until one day I realized I was using the male rat as a model for understanding human sexuality, human male sexuality, and human female sexuality. And it's so paradoxical that even in animal science, we're using male models to understand female conditions.
According to a report by the U.S. Government Accountability Agency, about 80% of drugs that are pulled from the market every year by the FDA are done so because they have adverse effects in women. These are effects that presumably would have been caught earlier had that preclinical testing included both sexes. It's our tax dollars, right? And science has to serve society, not one half, but the whole damn whole, right? Women are 50% of the population, but only 10% of NIH dollars goes to conditions that primarily affect women. Only in 2016 have we reached the point at which our bodies are being taken seriously for the first time. We're living history here. This is new. There is a lot to be hopeful about. President Biden just signed an executive order requesting $12 billion in new funding specifically to advance women's health research. This just happened in 2024, right? 2024, we have now a White House initiative on women's health. We didn't have that before. This is something of a watershed moment for women's health.
This is probably, I think, in our lifetime, ladies, one of the most important things that we'll do for ourselves. And it's really important that we all stand together and lock arms. And I am beyond honored to be here and be a part of this movement that's happening.
The Advancing Menopause Care and Women's Midlife Health Act is an act, a bill, that I've been a big part of getting passed. Advocacy became supremely important to me because I knew that this was a subject that needed to be talked about. It was a subject that had long been overlooked. And so I thought, I'm going to go to Washington and I'm going to talk to my female senators and House of Representatives, and I'm going to tell them what the issue is, what I'm experiencing, and ask them to come together and help erect a standalone bill that will give money, new dollars, just for menopause and women in midlife. And it's true that it's such a stigma around menopause and what that means for a woman, and the fact that we're old and we're no longer valuable to society. That's how we're viewed. I realize there's that stigma, but I'm not afraid to get in front of this, right? This is the most normal, natural time in every woman's life. We make up half the population, and every woman goes through this time if she's blessed enough to live long enough. We are, in many ways, the cornerstone of our society. We birth children, right? We give our bodies to procreation so that we all can be here, men included. Why are we discarded when those years are over? Not okay. And that's why I went on my journey, because I knew that I had to.
I realize it sounds strange to say this in a class about menopause, but there's so much about the biology of menopause that we don't know because science doesn't study people like us. So if women feel like they don't have answers, part of that is because medicine has failed women for centuries. We are confronting a medical system that was never designed to serve them. We're confronting a research that is still in its infancy.
You know, I started going to my doctor and I said, I think I'm going crazy. Something's wrong, you know. Funny enough, my doctor never, ever brought up the idea of perimenopause. I even go to a female gynecologist and no one has ever said anything to me about perimenopause.
So I was telling my doctor that I felt that's what I had, and she just kept telling me, I'm too young, I'm too young. Even knowing my history with my uterine reconstruction. So she just would not listen to me.
I did call my general practitioner the other day to describe some of these things. I'm 54, I'm kind of happening. And she was very kind, but she kind of said, you need to call your gynecologist. This really isn't a general practitioner. So I think that's also part of the problem is where do we go to have the conversation, and everyone's playing a little bit of hot potato. So I think there's a bit of a vacuum of knowledge.
When you look at the doctors who typically would treat a menopausal or a postmenopausal individual, they're going to be OBGYNs, general practitioners, internal medicine doctors. And a recent study from 2019 showed that a little over half of those doctors get one course in menopause training after they've done their education. One course is just not enough because we know that during the menopause transition, a lot of things happen. And this is complex and nuanced, so we really need to have in-depth training to direct patients to the correct interventions. If you're someone who's African American or identify as Black, or you're Native, Indigenous, large studies show that you're likely going to go through menopause sooner, your symptoms are going to be more severe, and they're going to be longer. So knowing this information is going to help you to prepare and to plan. Also, you're part of a group that has more trauma, more generational trauma, more microaggressions, macroaggressions, and knowing that you have this history of trauma, you know, that sets you up for worse symptoms.
We know that there are health inequities that disproportionately impact certain groups of females. We know that gender diverse, including trans people, face among the worst health inequities among the different populations of people who are seeking help. And for the trans man, so assigned female at birth, and therefore may have menstruated and may experience perimenopausal symptoms and go through the menopause, it can be incredibly embarrassing, even traumatizing.
In my trauma research, when you look at experiences that can be potentially traumatizing, if something just happens to you, then you tend to self-blame, then you tend to internalize shame. So that internalized shame and blame leads us to suffer in silence.
If you can't talk about something, the implication is it's shameful. So I think that the very first step is the discussions, is saying, this is happening to me. There's nothing shameful about going through menopause. There's nothing shameful about aging. There's nothing shameful about letting your hair go gray or not letting your hair go gray. There's nothing shameful about whatever you decide to do for your own, your own well-being, but to have those discussions.
Society tells us that everything is over, but we know this is not true. This is the framework that I want you to work with. I want you to look forward to getting older, to dismiss the myth that you're no longer valuable.
We have to realize it's okay to put ourselves first. It's okay to put our health at the forefront of our life. When we get to midlife, it's when women usually lean out of the healthcare system. It's time to lean into our health.
The dismissal that so many women and so many peri- and postmenopausal women express when they find the courage to ask for help is devastating. It's inappropriate, and it has to stop. And of course, fear arises, and when people have been so dismissed, they're going non-traditional routes.
Social media can be fantastic in the way that it can connect people with communities. It can help people find evidence-based providers, but it can also be a place where fear is sold, where you are given false information about hormone balancing, about supplements, about menopause hormone therapy. If you're taking a product that claims to have a health benefit, right? It can help hot flashes, it can help with metabolism, it can help with weight loss, it can help with mood swings, whatever. Know that that has not been tested in any rigorous way.
These supplements are not regulated by the Food and Drug Administration, the FDA. They may actually interact in your body in a way that you don't know what they're going to do and make your symptoms worse.
So when we talk about menopause hormone therapy, evidence-based physicians are talking about pharmaceutical medications made by a pharmaceutical company. There are also compounded hormones that come from a compounded pharmacy. The way compounded hormones are often spoken about online is this is a custom-made product for you. And this is not supported by any science at all. Someone going into a pharmacy and mixing up hormones with a weight and a scale can't create that same precision that you get from pharmaceutical companies. But even more, beyond that, when you get a pharmaceutical product, they're all batch tested, so you know what's in each one. I can tell you reliably how much estrogen is in each patch. That doesn't happen with compounded medications. They're not batch testing these products, right? So the problem with those medications is you may not be getting enough of them, or you may be getting too much. And if you want to take a medication, don't you want to know that you're getting the right amount?
So it's really important to stay clear of things that are not regulated unless you're talking about them with your doctor because you want to make sure that you're not making your symptoms worse and that you're not harming your body. You only get one.
Now, I fully recognize that there are so many barriers, that there aren't, countless healthcare providers waiting in the wings to offer support for the women who have been dismissed by a certain healthcare provider. But you have to become an advocate, right? You need to advocate for your own health.
I would tell women to take their perimenopausal, menopausal journey into their own hands. Read, 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 read. If you find that you have doctors or healthcare professionals that don't understand the menopausal body, I say have the courage to switch your doctor. I think as women, we sometimes have a hard time advocating for ourselves. So if you have to change your doctor and you have to find a doctor who's female, who has gone down this path or who is going down this path, I say do that. I would recommend going to the website, the Menopause Society, which is a leading organization focused on women's health during menopause. It offers essential resources to help you find certified practitioners who provide expert, personalized care for your menopausal journey.
In some cultures around the world, getting older is seen as a blessing. People who get older are valued. They are the cornerstones of the community. They're seen as sources of knowledge because they have expertise, they have knowledge. So they are celebrated.
It's a time of life I've discovered that's filled with joy. Because you know why? You're completely who you are. You have zero fucks to give. And that's a magical time of life, in my opinion.
You get to continue living life, doing the things that you love with the people that you love doing them with. So we have to start reframing our narratives.
The theory behind menopause existing is related to something called the grandmother hypothesis. And the idea is that reproducing is hard. And it was even harder 10,000 years ago, longer than that. Reproduction was hard. It's surviving childbirth. It's having shelter. It's gathering enough food so there's enough energy to breastfeed and enough energy to heal, to raise that child until they can gather food and resources for themselves. If you have an extra pair of hands, it's probably easier.
A lot of scientists are now coming to this understanding that menopause is this evolutionary adaptation, and we live longer than men, right? If you look at all the centenarians walking around the planet today, 80% of them are women. So it could be that something about the menopausal experience is what can explain women's increased longevity. That's pretty damn cool.
Human beings continue to live and thrive and continue being active and valuable members of the community because they're supporting their tribe. So we're making contributions as a whole, and we are meaningful. We belong here. We have a purpose.
Our responsibility is to teach younger women, prepare them for what's coming, because girl, it's coming. There's no, this is a huge part of life.
And there's so much collective wisdom in the community that we really need spaces to share it.
When we can have a conversation, when we can say, this is what I go through and this is what I've gone through, you instantly feel less crazy. You feel, oh, thank God, I'm normal.
So I'm very close to my college sorority, and we're all there to support each other. Yes, have you tried HRT? Have you tried magnesium on your feet at night? Oh, I'm a big Advil PM person. I've held all of their hair while vomiting many, many years, so this is not a group of women that should be trusted with any medical advice. But they're emotionally fantastic.
It's important to have a community to talk about this. Don't feel as if you're going through it alone. Open up. It's okay to be sad. It's okay to share these emotions. In sharing, you may be actually helping someone else.
Community is key, right? Well, Respin has been my baby Once I realized that I was in perimenopause, I had this aha moment and I thought, let's educate, let's inform, let's raise money, let's change the world for women. And the camaraderie of that is beautiful. And I've heard women who have gone through menopause and who are on the other side tell me, it's the biggest joke nobody understands. It's great over here. It really is. If you know the right things to do, if you have the medications, if you have all of the information, I want every woman to arrive on the other side of that as their best selves.
So when it comes to the postmenopausal, like my mom, for instance, right now, she is 63 and she's been done with her period for 10 years already. My grandma is still here with us and she's 80-something and she's been done. And they are free and they don't have mood swings, at least related to PMS. But, you know, it is a certain freeness in that.
If I could redefine menopause, first of all, I wouldn't use that word. I would choose another one because that word has been so stigmatized and there's such a negative connotation with that word, so I would change the word.
Back in the day, we used to use the term climacteric, which I love because it's more about a phase of life, a rung on a ladder, a step that you're going through. It encompasses a lot more as opposed to defining you by the date of your last period.
I want you to start challenging your idea and your imagery as to what a woman going through menopause looks like. So looking at someone in their 40s, 50s, 60s, who you admire, who you look up to. Do you think about menopause when you see them? No.
We need to learn how do we define ourselves based on the things that are important to us, not based on the messages that society gives, and recognize that the status of being mothers is only one part of it. And that's why, again, it's so important that we're having this conversation.
The definition of menopause, a journey, an awakening, that's the word.
Oh, there's absolutely a freedom. Listen, no pregnancies, no periods, no PMSs. I guess this is my transition to total freedom.
I don't always feel that pressure of having to be a certain way. And I think that's one of the beautiful things about getting older in menopause, because there's a point where you just don't care. You're like, this is the way I am, because older women don't just wear Depends. We like to wear cute underwear. I wear a thong.
Do I look old and shriveled up, honey? I'm looking real good.
I'm in that next phase. I leveled up. That's how I see it. I leveled up.
It's another part of life. It's the next phase in your womanhood, in my womanhood. And the more you know about this, the more you can live.
For so long, we've been valued by the way society sees us. We get to decide our worth now. We get to decide who we are in the second act of our life. Let's change that narrative together. Just like we have bachelorette parties and baby showers and bar mitzvahs, bat mitzvahs, I think we should have a siesta for women when they realize that they're in menopause. And their families should throw it. They should usher you into this new phase of your life with joy, with love, and with support. And they should honor you that day with a siesta. Because now you're about to enter one of the best times of your life.